Good morning, everybody. In last 16 years of my practice, I have been looking for a thrombosuction devices, which has to be effective. Many a time we know in intervention, initial days we used to use them very frequently. Then came the time, then they went out of flavor. Everybody started using with the GP2 inhibitors, Brillianta coming in. The use of thrombosuction has gone down and it never come to the class 1. A typical story, a guy with infarct, and we see the LED, which is 100% occluded like this. We know this is thrombus only, predominantly, nothing else. RC is normal. PAMI situation, we try to push a wire blindly. We try to balloon. Initial days, we used to put a thrombustor, but everybody know the thrombustor are very stiff to go inside. The caliper is very low. When we aspirate, many times we pass multiple passes. We really don't get the thrombus on this side of the mesh, and we are stuck. And we don't use the thrombus suction many times. We see the no flow, no reflow, and then we are stuck with giving adenosine, niporandil, SMP, and everything, and then we are stuck with the myocardial damage. So this is the one new equipment I got, is the CAT-RX, the mechanical thrombectomy device, which is of larger caliber, and it has got constant negative pressure by the machine, and it absorbs the thrombus. Initial days, I started using this thrombustor, the CAT-RX, for the pulmonary cases. This I have been using for almost a year now. I treated a lot of pulmonary thromboembolism cases on the oxygen, RV dysfunction, hypoxic, hypotension. I use this and the thrombus clear on the eyesight, and then ultimately patient drastically improve. So I used almost 5-6 CAT-RX for the pulmonary initially, and I was actually waiting for this for the coronary indication. So this I did the case, a couple of cases. We can actually see the chunk in the mesh of the machine, which creates the negative suction basically. So this equipment I have found very, very user friendly. The way it passes in the coronary. First one I show going down the LED was very smooth, although you can see the suction lumen is quite big. It can suck a thrombus. And one very interesting mechanism I found, against the contrary, we use the thrombustor, is what they taught us doing is go proximal to the thrombus. Don't go across as we go with the thrombustor and take multiple runs. Go proximal to the thrombus. Keep that machine in a negative mode. It keeps sucking and suck the thrombus. Once the thrombus is sucked, it goes the continuous blood flow. You can see it is stuck with the thrombus, and with the pressure, it goes away and the free flow starts. Then you go a little further, then suck the thrombus. And this is the way you go down the line so that complete thrombus is taken over. You can see the diameter is 5.3. Obviously, it cannot be used with the guide liner or buddy wire, but then lumen is quite big. And to my surprise, it passes against the mechanical thrombus aspiration. It does smoothly goes across the curves. And reuse, because I had to reuse for the obviously financial reasons, but the reuse is also equally smooth going in. So this is the new kid on the tech. I found it very good. This is how the engine looks like. It is a negative pressure, almost 30 atm, and it is the continuous negative pressure. Whereas we suck with the syringe, when some fluid comes in the syringe, the pressure drops down, so we cannot maintain that. And the innovative thing is that we have to go to the proximal segment, and this is how engine is there. You put the catheter, connect the catheter. Once the engine is ready, you make the switch on, and then it sucks this thing. As far as the trials are concerned, there are no many trials supporting the thrombus suction. Still, it hasn't come to the class 1 indication, but many times we know it is thrombus, and it really helps in our practical this thing. Initially, I use this thrombus suction because it gives sustained suction. The ease it goes below the line is very good. Many times we find difficulty in where this guy is going to be. So this Pumra engine, this is associated with the Sejanand. So you can catch up the Sejanand guy and tell them to get this machine, and looks very promising. I have treated initially pulmonembolism, massive, like we tried with thrombolytic therapy. You can see this particular diverter which can break the thrombus there. Unfortunately, I had no chance to use it because it was not available. But in pulmonary embolism cases, you can easily go into pulmonary arteries. We go by CT scan, and if we are sure, many times we go like this is the massive thrombus you can see on left pulmonary artery. And the catheter is quite malleable. It is very soft, doesn't harm. And you can see it, I have passed in multiple directions. It has got a little bent, and it can very good give thrombus suction. And you can see this as all cleared basically, and multiple runs on multiple branches. Obviously, you can manipulate with a JR or a multi-purpose, and you can enter multiple branches. After doing this, I had a chance whereby patient had a MCA infarct. Unfortunately, neurointerventionists were not available. Neuroradiologists were not available. I used this engine on the middle cerebral artery. With little manipulation, of course, we as a cardiologist, we have to learn how to manipulate in the cerebral arteries. They are very delicate. We cannot go very fast. We have to be very slow. Obviously, our technicians are there to hold us back. But this, even with this machine, I could do the mechanical thrombectomy of the middle cellular artery very successfully. Very soft catheter. So probably we can learn when young individual with multiple thrombus burden, we can see. We do give Brilinta, we give 2B3 inhibitors, but this thrombus suction looks very promising because it is very smooth. New thing it has taught me is go from proximal to distal, and runs are very smooth. You keep it very nice, clean, so you can reuse very smoothly. So looks a good kit on the block. Thank you.